Fantastic. So I think we'll go ahead and get started. So welcome everybody. It's the 18th Annual Oncology Nursing Day. Congratulations to all of you for everything that you do every single day for all of our patients, as well as for each other, and supporting ourselves individually and as teams through a very, very challenging year. This year, the theme is I am, I will, a call to action. And I think oncology nurses have truly stepped up this past year. We always step up, but in new and challenging ways. And we've really shined through what has been a challenging pandemic and context for nursing across all areas within oncology, from the front line right up through leadership. So I commend you for all that you do every single day. And thank you for being there for your patients and for each other. So just a reminder that this event is being recorded, and we will be making this recording available on our brand new YouTube channel after the event. Give us a little bit of time to figure out how to actually get it posted, but do watch your emails for some information on how to access the recorded link, as well as an evaluation survey. And so, yes, we're very pleased to have you here today. We have two fantastic speakers lined up for you. We have Elizabeth Bedard-Huber, who's the clinical lead for Serious Illness Conversations Initiative at the BC Centre for Palliative Care, who will be talking on serious illness conversations. And we also have Tammy Dyson with us today, who is a leader in medical assistance in dying at the Fraser Health Authority, who is going to talk about the MAID context. And so, as a thank you for joining us today over your lunch hour, any CANO members who are attending this in-person session or who choose to view this recording within 2 weeks of us finally getting up on our new YouTube channel, you can receive a small Oncology Nursing Day gift as a thank you from your CANOBC chapter to you for all that you do. And so to register for your gift for attending this event, we'll just ask that you complete a short evaluation survey, which we will send out with the link to this recording once we have it up on YouTube. And I also want to promote today as well, if you're coming from a meeting room viewing this presentation, or if you're talking to any of your fellow oncology nurses today who perhaps are not yet CANO members, now is the time to join, as CANO is actually offering a 15% discount to all new regular members who sign up for a 1-year membership prior to April 9th, this Friday. So if you are interested in becoming a CANO member, please do email CANO head office and they will give you a promotional code for that discount. And there are a lot of benefits to actually joining CANO, including you get a discount to the annual conference, you have access to a wide variety of awards and educational grants. Over $38,000 worth of awards were given out in 2019 alone. You also will have access to a lot of quality free education and resources through your CANO membership. And if you're CNA certified, you can actually earn your certification hours by maintaining a CANO membership as well. So please share this information. If you're not a regular member yet, please do sign up. And if you are, thank you for continuing to be a regular member, and talk about the benefits with your peers as what that membership brings you. And so to kick us off, I want to share with you guys the brand new Oncology Nursing Day video that was created by the local planning committee for the Niagara Falls Conference. Unfortunately, this year we did have to make the difficult decision to change the conference from in-person back to another virtual event. But the local planning committee did work very hard to create this new video for you guys to celebrate Oncology Nursing Day. And so bear with me while I pull up the video. Well, that's great. I'm always get a little bit emotional each year when I see these O&D videos because I know all the work that goes into them, and they're made by nurses for nurses to celebrate us on Oncology Nursing Day. So huge shout out to the nurses from the LPC for Niagara for putting together what I think is a really great video. But for now, I'm actually going to pass the reins over to Elizabeth Bedard-Huber, our first presenter, who is going to talk to us about some serious illness conversations. So Elizabeth, over to you.
Thank you, Andrea, and thank you for having me. I hope everybody can hear me okay. Before I get started, I just want to say that I'd like to acknowledge that the land on which we work is the unceded shared traditional territories of the Coast Salish people. And then just give a kind of a quick overview of what I'd like to speak about in the next few minutes is a real kind of a put it into context of why more, earlier, better serious illness conversations are so important and where it fits in the overall process of advanced care planning. And I'd like to describe the team's role and with particular focus on the responsibility of the nurse and share a little bit about what's been going on in British Columbia with regards to translations and adaptations, and then just give you a quick update as to what we've been doing through the BC Centre for Palliative Care. Next slide, please, Jennifer. So to put it into context, we know that earlier conversations about wishes and priorities benefit the patient, and that the majority of patients, when asked, prefer to die at home. But you can see here on this slide, many people are still dying in acute care, and many of these conversations are happening further along in the disease process in the last month before death. So we know that we need to do a better job of this. There is evidence that advanced care planning, end-of-life discussions, serious illness conversations reduce non-beneficial aggressive care at end of life. For example, decrease ICU admissions, decrease emergency room admissions, decrease the use of chemo in the last weeks of life. This results in better outcomes for the patients and their families, for the improved quality of life, and also for goal concordant care. Next slide, please. You might ask, well, where does the serious illness conversation fit in the whole scheme of advanced care planning? And basically, the key is that the serious illness conversation is clinician initiated and it's clinician led, which is a little bit different than advanced care planning that's more in the home, at the kitchen table, on a park bench. But here we're asking clinicians to identify somebody who would benefit from a serious illness conversation. And one of the triggers we use is the surprise question, not necessarily 50%, like full 100% foolproof, but it is one of those things that we do use to identify who would benefit from a serious illness conversation. The surprise question, would you be surprised if this person was to die within the next 6 months to a year? And the next slide. We ask ourselves, who's responsible to have these conversations? We all are. And the video, I must say I get emotional when I see those videos as well. They really just spoke to the role of the nurse and the role of the nurse in promoting a palliative approach to care, where communication is fundamental, so that we understand a person's wishes, their priorities, and that we align care with what they want. Next slide, please. So just to review, the concept of a palliative approach to care, our role as nurses or as part of the interprofessional team is to initiate communication that reflects a person's values and their healthcare wishes. We're responsible for honoring those wishes. We're responsible for providing comprehensive, coordinated, compassionate, and holistic care. And what I mean by all of that is making sure that patients and their families are linked with the resources that they need at a time when it would be the most benefit for them. We're also responsible to attend to pain and other symptoms relief and to psychosocial problems or issues that patients and their families are facing, grief and bereavement support, and we want to really maximize the patients and their families' quality of life. And we're responsible for advocating for resources so that we can give the support to persons and families in an area where they wish to have their support in their preferred environment. And all those key responsibilities were actually talked about in the Cano video that the nurses produced. It was really great. Next slide, please. So here's the Serious Illness Conversation Guide, and I think a lot of you are very familiar with it. And so I'm just going to give you just a quick overview. The left-hand side of the Serious Illness Conversation Guide is a series of prompts to sort of help the flow of the conversation. And we go through a setup. We assess the patient's understanding of where they're at in their illness journey and how much information they wish to have from us. We share a prognosis. We explore their wishes, their goals, their fears, their worries, what they're willing to go through, like a trade-off. And we also explore how much their family is involved and how much they know. We then summarize and, as necessary, make recommendations. But that's basically what the Serious Illness Conversation Guide looks like. Next slide, please. But it's not just the guide, it's an actual process. So in each clinic, we would have to go through a process of identifying who would benefit from that particular conversation. As I mentioned, the surprise question, it's not foolproof, but there might be other triggers that you might use in different tumor groups. Then preparing the patient for the conversation. That could be with a letter, or it could be actual conversation before the conversation, so to speak. Reminding the clinician, making sure that there is time allowed for this conversation, having the conversation, whether it be as a team with a nurse, a physician, or oncologist, social worker, oncologist, and then documenting to make sure that that documentation is accessible across settings. Next slide. Growing evidence affirms that these conversations are really important and that they benefit our patients and they provide better care. And we know that palliative care teams have worked as interprofessional teams for many years because of the complexity of the patients they see. But not everybody is going to see a palliative care team. And therefore, it's really important to work as an interprofessional team in primary care and in our clinics. And this is a study that was done in Boston within 6 primary care clinics over a period of 2 years to see how they could implement the serious illness conversation as part of their standard care. And what they found that was really, really important was that role clarity needed to be clearly defined, that everybody needed to know what their responsibilities were. Next slide, please. And this group worked with, I know this is small, but it's basically, they said the role of the physician, the nurse, and the social worker. Depending on your team, you might have dietitian, pharmacist involved, OT, PT. It depends on the particular team. But you can see, I highlighted in yellow here, the big overlaps when we look at that guide and how we could implement it into clinical practice. So everybody has a part in identifying the patient, preparing the patient, making sure there's time to have the conversation, and then having the conversation. Next slide, please. One of the key questions nurses and allied health have asked us when we do this education is it within my scope of practice to talk about a prognosis? And if we talk about, as nurses, if we talk about a prognosis as being uncertain, it can be difficult to predict what will happen with your illness. I hope you will continue to live well for a long time, but I'm worried that you could get sick quickly. And I think it is important to prepare for that possibility. That feeling of being prepared, hoping for the best, but making sure that you have a plan just in case it doesn't go the way you hope for, is definitely within our scope of practice. As is if we were talking about functionality. I hope that this is not the case, but I'm worried that this may be strong as you feel, and things are likely to get more difficult. Again, this is definitely within our scope. The other suggestion they use in the guide is the time-based, where a prognosis is looked at in ways of time. And that is definitely the oncologist's or the physician's or the nurse practitioner's role. That wouldn't be ours. Next slide, please. So as I said, it did come to our attention that nurses in allied health were concerned about using the guide, whether or not they could have that type of conversation. So a group of clinical nurse specialists and nurse educators got together, and we worked on providing extra tips for allied health and nurses to use the guide, especially focusing on the prognosis piece, but also on if you could use questions from the guide in the process of care, which there's a section that we added in there for that. And next slide, please. And we actually wrote up the whole process of adapting the guide to provide those extra tips. And if you're interested, that article has just been published in the Journal of Hospice and Palliative Nursing. Next slide. Just want to quickly tell you what's been happening in British Columbia. Vancouver Coastal has done 11 translations, and they've also provided a module on the Learning Hub for translators to actually access, just so that they understand the spirit of the guide, that it is a listening conversation to understand a person's priorities, wishes, and values. And next slide, please. Also in BC, we have adaptations. Fraser Health had a team led by Dr. Charlie Chen, who looked at the guide and adapted it for substitute decision makers. And at Canuck Place, Kamara Van Bremen and her team adapted the guide for pediatrics, for having the discussion with parents, but also with youth. And next slide, please. We also introduced the Serious Illness Conversation Guide to nurses working in First Nations communities. And they were a little concerned about the cultural safety of the guide. They felt it was too white, to be honest. And so what we did is we, with Fraser Health, First Nations Health Authority, we explored what needed to be adjusted in the guide, and so we adapted it. The language is much more direct. The emphasis is more on family, and the feeling that there needs to be asking of permission throughout the guide, not just at the beginning, but in the middle and in the end, and always checking in with the patient. And also we added a dignity question. What do I need to know about you to give you the best care possible? And next slide, please. This is also published in an article. And if you are interested in the whole process and the rationale behind the adaptation, you can see this article in the journal, International Journal for Indigenous Health. And that is open access, and the link is there on the slide. And next slide. I just want to close off with saying that we've been doing a lot of training from all resources across British Columbia, not just the BC Centre for Palliative Care, but Anthony and his team has done a lot of work. Renal have done a lot of work. All the different health authorities have worked very hard to train clinicians to have these types of conversations. And I know this is a little outdated, this slide, but I just want to show that 64% of the people that have been trained over the last 4 or 5 years have been nurses. And we now have 185 facilitators in BC and 38 master facilitators who train those to train other clinicians to use the guide in practice. And my last slide, just to thank you. And you can access any of our resources through the BC Centre for Palliative Care. And also I put Ariadne Labs up there. Ariadne Labs is connected with Harvard Medical School, and they were the group that actually developed the guide in the first place. Thanks.
That's great. Thank you so much, Elizabeth, for providing us with that quick overview and update on, what is, I think, a really critical topic for our nurses. I think we all recognize the population that we work with and the importance these conversations hold in directing and supporting our patients along their cancer journey. So I am going to open it up for a few minutes for questions or comments from everyone. Feel free to type your questions in the chat, or if you're comfortable coming off mute, you're welcome to do so. And I'm just seeing here, Anthony Porcino from the EPIC program at BC Cancer has a comment. So Anthony, did you want to say anything about what is available through training?
So right now we mostly have just the regular SIC training for anyone in BC Cancer. Certainly if there are spaces available, we can include other people as well. We haven't got any sessions set up at the moment, but because we're now doing a lot of the trainings virtually, we can set them up for smaller groups on an as needed basis. So our EPIC team is happy to try and work with you to get that training if you're interested.
That's great. Thank you so much for sharing that, Anthony. And so coming back to your presentation there, Elizabeth, a couple things really stood out for me at least. And, it's been a while since I think serious illness, the topic and the advanced care planning was first introduced. And I remember at that time seeing the serious illness conversation guide and thinking, what a great resource this is. And it kind of fell off my radar, to be honest, that we had such a great toolkit. And for me, even those examples that you shared of how to have those conversations, just the starting conversations as a nurse, acknowledging that prognosis piece. I don't know if we're able to go back to that one slide. It was the how to share prognosis slide. But I think that's really tangible, I think, for our frontline nurses and those who are interacting directly with patients, saying, how do I even start this conversation? I recognize the value. What are the words? That's the one there. Thank you. This is the sort of thing I'm guessing is in that information guide or that reference guide that you've created for nursing and or the interprofessional guide, correct? Yeah. And how has that been received? Are people giving you more feedback or asking for more examples on how to have these conversations, or what does that look like currently?
I think on the whole, people have been very receptive to it. They use this wish, worry, wonder. I wish things were different, but I worry that things could get worse. And I wonder if we could have a conversation about that, or could we plan for the future? So what that whole wish, worry, wonder framework that Ariadne Labs introduced, they talk about it kind of softening it and sort of aligning the fact that you're saying, I wish things were different, you're aligning yourself with their hopes, the patient's hopes. So it's not like one doctor I remember saying, I don't want to beat the person over the head, right? That they've got this disease. Can we not soften that language? And this is something that they've come up with. It's interesting. In Canada, we've had a lot of, response or concern about the word worried. They don't like the use of the word worried. I don't know if it's because Canadians were just too polite, but they say they would rather see the word I'm concerned. But whether it's concerned or worried, the idea is still there that we're going to all hope for the best, but let's plan for just in case, a plan B.
That's great. I love that wish, worry, wonder. It's a very simple way, I think, to frame, at least for me, if I was still in clinical practice, which unfortunately I'm not, just to give me that starting point on how I might even approaching that. But I'm in thinking about, you know, who we have coming up speaking next with Tammy Dyson with medical assistance in dying. Do you have any tips or suggestions on how nurses might navigate the serious illness conversation that might head towards a conversation about MAID?
Well, I think that when we're exploring people's goals and their worries, their concerns, there's also a question in there about abilities. You know, what abilities are so important to you that you couldn't imagine living without? And I can see that segueing into a conversation about MAID. So, for instance, you know, many times when I worked here at the Cancer Agency in Vancouver and also at Vancouver General Hospital in palliative care, one of the biggest things I heard from patients was, I don't want to be a burden on my family. So when I can't do my personal care, I can't get to the toilet, et cetera, this is where and I don't want to be there anymore. And that ability question could segue into something like that. And you know, we're not saying that we would start having that conversation, but it would be our responsibility then to, when we're summarizing, saying, now, if the patient wants to explore that further, making sure that we actually connect them with the resources that they would need. You know, the people that would actually follow through or assess them. I think that would be a nice segue into it there. One way.
That's great. Thank you for that. And so I'm just going to look back to the chat. Were there any other questions from anybody who's viewing either in a room that would like to speak, or feel free to type them in the chat?
If I may, this is Anthony here from EPIC again. Just it sometimes comes up. SIC does have a special place for being recorded in Cerner as we transition to the new electronic medical record within the advanced care planning and goals of care area. And I believe that is happening in Vancouver Coastal Health. So that information will be shared for patients and shared with all healthcare providers.
Excellent. And we at the provincial level, there's a lot of conversation how we can share it across health authorities, you know, throughout our province. And so there's lots of ideas and people are coming together and sharing. So I think everybody is on board that this is important information that the patient and family shouldn't have to repeat over and over again.
This is Michelle. Just one quick comment. I think that these are great cues and skills and ideas for nurses to incorporate into their practice. Absolutely. For me personally, this spillover has gone into my own personal life. Where recently, one of my parents passed away, and I have to say that some of the gentleness of the cues and the sort of like opening phrases to kind of just begin to have those conversations within my own life, which then spilled over to other family members that saw that sort of approach and was able to sort of mentor them to then go forward and feel more comfortable with being open, having conversations as well. And so it's super powerful to just take this information as well as nurses, but into our own private worlds, and then see how that then filters to other people in our lives.
Thank you for sharing that, Michelle. I mean, that speaks to the impact that this can have on patients, their family members, even us as clinicians. And sorry, Elizabeth, I think I might have cut you off there.
No, I was just saying thank you. And one of the things that nurses did talk about was, you know, the informal conversation. It might not necessarily be an appointment where you sit down and go through a conversation, but maybe there's in the process of care, you're doing wound care or you're doing chemo or and somehow there's an inkling, or you can open that door and have a little bit of a conversation. And if you have a look at the guide, all the questions are pretty much open-ended. So they can bring that forward. And actually, Michelle, I did use it with my mom who passed away 2 years ago, and it helped me a lot.
That's great. Well, thank you so much, Elizabeth, for getting the ball rolling with the conversation today. And actually, I'm going to move us along and call on Tammy now to share with us a discussion on MAID. So welcome, Tammy, and we'll pass the screen over to you.
Great, thank you. Let me just do a little bit of the share screen, and Andrea, I'll look to you to make sure it's coming out okay. Technology and myself are not always the closest of friends, so.
I think all of us in nursing feel that way as well. So, but we are seeing your screen.
Excellent. Okay. And thank you so much, Elizabeth. It's always great to hear you talk, and such really good, meaningful and rich work and discussion that is happens with those serious illness conversations. So thank you for that. And a little bit of a segue, Andrew, you kind of tried to bridge it a little bit in terms of where MAID and those discussions can take place. So hopefully providing you a little bit of information. MAID is certainly in the news quite a bit as legislation changed last month. So hopefully I can provide you a little bit of more information and certainly shout out with any questions at the end. So I jinxed it because that's when I said, oh, there we go. Okay, my slides don't always advance. So I'll just go over a little bit of the changes around the legislation and around what to expect going forward, and most importantly, where to get additional information. So with Bill C7, which is what was passed on March 17th last month, it is it's a change, it's an evolution from what was previously known as Bill C14, which was the MAID legislation that we have become familiar with over the last 5 years. So much of it is actually the same. What is different, most significantly, is that one's death does not have to be reasonably foreseeable. So that was never defined in the legislation around what reasonably foreseeable means. That was intentional. You weren't missing anything if you couldn't figure that out. It was up for interpretation. That has now been removed from Bill C7, and there's also been an introduction of the waiver of the final consent. So if one's death is considered to be reasonably foreseeable, then a discussion can be had with the MAID prescriber, with the patient, to determine if they have a specific date that they want to proceed. They can do so if this particular form is complete, and we'll talk about that in a minute. But most significantly, those are the most significant changes. With the changing, there's also the safeguards within the legislation. Also, some stayed the same, and also there was some that were also changed. So most significantly around the logistical process in requesting MAID is that now it is only one witness instead of two. And also that one person can be someone who is providing care. So previously it was two people and both people cannot be the one providing care. How I would see this play out in acute care settings is previously is that there would be a request, and either the PCC or the social worker shouts out to their colleagues within the hospital in the setting and says, can you come over and can you witness? That is how it was done in the past, and now it can actually be that bedside nurse or the social worker or the PCC if they feel comfortable doing so. There's no expectation, or does that mean that they absolutely have to? But it is something. It was Health Canada saw that actually as a barrier by having it be two people not providing care. So there's also and we'll talk about the two different tracks in a moment. So when one's death is not reasonably foreseeable, there's not a third assessment, but one of those assessments needs to be a consultation with an expert in the field of the area that's causing the person's suffering. So there must be that additional consult. We emphasize it's not a third assessment, but that does need to take place when one's death is not reasonably foreseeable. So essentially with these changes, it has become a little bit of a two-stream or a two-track system. So when one makes that initial request for MAID, it is determined whether or not one's death is reasonably foreseeable. You may be wondering who was making that determination, and it is by those doing the assessments. So depending on the outcome of those assessments, if one's death is considered to be reasonably foreseeable, there is no longer a waiting period. So previously there was 10 days where one had to wait in between the request and when the procedure could go ahead. And so that is now, there's not a waiting period. There still needs to be the 2 medical assessments by either a physician or a nurse practitioner. And again, then there's that waiver of final consent. So again, that waiver of final consent, it can't be for someone that says, I would want to proceed when I am no longer able, when I'm confused or when I'm no longer able to speak for myself. It has to be with a specific date for that. And it's essentially, it's an agreement between the person and the MAID prescriber. And again, that reasonably foreseeable, it's not intentionally defined within the legislation. So when one's death is not reasonably foreseeable, there's now a 90-day waiting period. And that 90-day waiting period starts from the date of one of the assessments, of the first assessment. So it's not from the request record, which it was before, it's from the date of that first assessment. That is when that 90-day period can start. And again, as mentioned, there's that the required consultation from an expert within the field. And having that waiver of final consent, it's not applicable for one whose death is not reasonably foreseeable. So I'm throwing a lot of information. There's not going to be a pop quiz here at the end. I did neglected to mention I will send these slides to Andrea after, so you can certainly have them as well. A lot of information on this slide, but given the audience here, I thought it most relevant in terms of those that are proceeding with MAID. 65% are those with malignancies. So this is data specific. The top left here is specific to Fraser Health. So it continues to be most with people living with malignancies. With the change in legislation, we're actually not expecting a huge, we are expecting an increase across the province, but not a significant increase when we look at data from around the world. When there has been similar shifts, there hasn't been a huge increase. The information in the top right-hand corner is distributed from the Ministry of Health, gives you an idea around how often MAID is, the provisions itself are occurring within the province. This is only for the completed procedures, so this does not account for how many requests are made, so that is just completed provisions. Speaking of just having those requests be made, if you drop down below that in the bottom right-hand corner here in Fraser Health, and I pulled this up, this is our data from just this morning, so it says per April, but it's per April 6th. When we've had a little bit under 1,500 formal requests for MAID since 2016. And when we receive a request for MAID here within Fraser Health, we break it down to one of those categories. And we actually realize that about half of the people that do formally request MAID never proceed with a procedure. They will either die naturally not requesting MAID, or they will deteriorate out of eligibility, so they are no longer able to consent for MAID. We're expecting that to change a little bit, having that the waiver in place. But just anecdotally, for the last few weeks, we're still seeing people that have the intention to proceed with MAID, but then deteriorate out of eligibility or are dying naturally. So many people request MAID, and so many people with malignancies request MAID and then just want to put everything on hold. I am sure many of you here on the call certainly can appreciate someone who's told you that just having the MAID paperwork in place gives them a sense of comfort and reassurance that it's their, we call it the back pocket scenario, or the plan B, for those that just want that, that reassurance. And I can't tell you how many times I've talked to patients and they say, you know what, just getting my request in and knowing someone's coming out for that assessment, I feel so much better. I feel that I'm so much more ready to take on each day, knowing that that is an option. It's that element of taking control back. So in the bottom left there is just around where MAID is occurring. So Elizabeth, it certainly stood out to me in terms of the deaths, certainly mostly happening within acute care. For MAID, it is predominantly within the community. So in having those conversations about serious illness, I know in my days of palliative care, sometimes I would just ask, what does a good death look like to you? And that is relevant to MAID or without MAID. And what defines that? And what does that look like in terms of a good death for them? And I learned to always be prepared to be incredibly surprised with that question. So in terms of what is on the horizon, there is embedded within the bill itself, there is a mandatory for a Senate and a House to come together to do a comprehensive review within 1 year. So to really look at the safeguards that are in place, and to see how everything is going across the country. Within Bill C7, it was also stated that mental health is the sole underlying reason for requesting MAID will be permissible in 2023. So we were not expecting that. We were expecting for the one's death to not be reasonably foreseeable for that to be dropped. This did come out of left field a little bit in terms of us. So it gives 2 years for the health authorities, for the province, for Health Canada to develop those safeguards and to be able to have that be available to Canadians. And also there's now the collection of race-based data. So just in terms of being able to identify where there's gaps in healthcare for more marginalized groups living within the country. So I would not be a palliative care clinician in my previous days if I did not always start by saying it's important to always lean in with curiosity when someone is requesting MAID and to ask why. With MAID being legislated, I find that very well-intentioned people would just jump to getting the forms. It's important for us to go back and do the work that we've been doing for 20, 30 years, which is to lean in and to want to understand more around why that person is requesting MAID. It always does break my heart when I receive a request on my end and it's for someone who has very poor symptom control. And when I look them up on the EMR, I see that they are not connected to any palliative care program, that they are not connected to any support in the community. And it's not uncommon for us to initiate those referrals into that support, and then we don't hear from them again. So that does indeed happen. All the forms specific to MAID will and should always be downloaded off the Ministry of Health website. So you will think that your health authority, while they will have really good information on hand, the direction will always be to go to the Ministry of Health. So when they make changes to the forms, if there's tweaks in the legislation or anything that happens, the Ministry of Health will update their forms. And we direct people, whether you're a physician MAID prescriber or a family member. And just to know that MAID eligibility, while sometimes people will think that it's Fraser Health being really difficult, that we're not proving someone, it is actually federal legislation, federal regulation, which has the, it's how it is carried out is specific to the province. And here in British Columbia, it's by the Health Authority. So in every health authority, there is a MAID care coordination service. So here in Fraser Health, we are a very small but mighty team so that we will respond to every request, whether one is a patient or family member, friend, physician, nurse, does not matter. I'm here to happy to answer any calls and direct someone to where they need to be. Through Learning Hub, there's also some great courses that are also just in the next week or so are being updated to reflect Bill C7. The Ministry of Health is actually a really good resource as well. And then if you're here in Fraser Health, we have a lot of our information is up on the Pulse page. So as I mentioned, across the province, all of the equivalent of us across the province, we're actually all quite well connected. So I can say as a fact that each of the people behind these care coordination centers across the province are lovely people and can certainly serve the same function and process that we have to direct people to where they need to be and to get the information that they need. So that is a lot of information thrown at you in a very short period of time. So happy to answer any questions at all, or if you see any more of that, your reflections around the crossover between Elizabeth's presentation and this as well. I'd be curious to hear what people feel.
That's great. Thank you so much, Tammy. You're right. That was a lot of information. I didn't realize there was that many little changes in the legislation. Yeah. And, you know, my ears went up a few times during your presentation, but we do have a question already coming in from Sally Thorne, and it's, Tammy, do you foresee that many of the cancer MAID requests will fall into the not reasonably foreseeable category? And if so, how might those assessment conversations influence the serious illness conversations Elizabeth was talking about?
That's a really good question. And yes, I mean, in the last few weeks, I certainly can't say that we've actually had very few requests for people that would fall in the non-reasonably foreseeable death category. We've had, so I can't really speak from experience. I do, I mean, as the data shows, most of the people with malignancies, they do certainly are requesting MAID. I do, and again, I don't know if this is my palliative care hat on or not, but what I do find is, for those of you familiar with the PPS scale, I find that when people are transitioning between the scale of 30 to 40 is when people are reaching out to us and they want MAID right now. And I think it's because they might theoretically know that maybe what they're up against, but then when they are not able to get out of bed, when they are more reliant on others for care, they want MAID right now. And it's, again, I feel it's taking that control back. So having those conversations at a point when they are not in those really acute changes of function, of really tangible and observable function, I find is really helpful. A lot of other programs will get really frustrated with us saying, why are you calling us with such, late requests? And it's often it's because of that scenario. Someone's PPS of 20 or 30 and they want MAID right now and they don't have the gift of time to wait until next week. So none of us like those really quick turnarounds. They're stressful on all of us. And but to be able to have those conversations and to be able to find that clinical finesse around how to, it's not a conversation about MAID, it's a conversation on what is important to them as they're approaching death.
Mm-hmm. Yeah, thank you for that. Elizabeth, do you have anything you'd like to add?
Sorry, I was muted. I think Tammy said it beautifully. I think that it's all about choice and taking back that control. And so I really understand that. And I think the serious illness conversation can help people think about their future and their future planning. And that might include MAID down the road. I think it can kind of support each other. I think that conversation can support those, making sure that the person is getting what they need and the support they need. Yeah. Well, thank you, Tammy. That was great.
Thank you.
Yeah, thank you. And I really, one of the things that actually struck me during the presentation was you talking about how you get so many referrals due to poor symptom control. And, how maybe if we were a little more proactive with having these serious illness conversations and understanding the value to our patients on what they actually need in this journey, MAIDs might still be part of that conversation, but it might not be so urgent. It might not be the thing that initiates the conversation. The goal here is to have that before they hit that point. So thank you for that. Any other comments or questions from those who are joining us on the call today? Again, please feel free to put them in the chat or come off mute. And so we do have one that's come in here from Scott. It says, thank you, Tammy. It's awesome to hear that MAID programs are now collecting race ethnicity data. How are other equity-oriented indicators being captured in MAID data to detect potential inequities in assisted dying?
Mm-hmm. It's a really good question. So it's just as it always has been just the demographic, age, diagnosis, location, and again, just around the provisions themselves. There is more information that is captured from the Ministry of Health, and we're waiting for their report to put out by that. And I'm also quite curious to know the differences between C7 and C14 and what that looks like. But I stand beside you that I too am very grateful that there's the collection of that data. And yeah, that has been the only significant change that has been legislated.
And that's interesting too, and it makes me think back to your presentation, Elizabeth, where you shared how the Serious Illness Conversation Guide has been translated into so many different languages, and even the work with the First Nations group on updating the guide so that it was culturally sensitive for their care. Is there also data being collected on that side that we could potentially cross-pollinate or look at all these various data points and work that's being done?
Well, right now there's the only data is, looking at how many emergency visits somebody has in their last months of life, those kind of things. But what we really need are patient outcomes. We need those quality indicators where we have a conversation with the family after the fact, a conversation with the clinician after the fact. And we have a provincial collaborative group that is kind of looking at some of this work that needs to be done. Hasn't been done yet, but definitely there is a need. Absolutely.
That's great. Thank you. And so just a comment from Jennifer. Thank you, Tammy. I like how you mentioned it isn't so much a conversation directly about MAID, but about what is important for future care. Within our nursing scope of practice, what are some suggestions as to how to present this as an option?
You guys are asking really good questions. And I don't mean to keep referencing back to my palliative care days, but I'm a variation of what Elizabeth had mentioned. Is I know something that I would often say is I stand beside you in hoping that you're going to get better and that you have a long life ahead of you. I stand beside you with that. And are you in a place to talk about it if that does not happen? And what does that look like to you? What is important to you? And if, depending on where that goes, it's, then I'll ask a little bit more pointed questions. Do you see that in acute care? What about being at home? Who would you want to have around you? And then from that, it's to be able to shape and to guide a little bit more specifically. It is with MAID on as a landscape and as an end of life care option. I feel that we are still learning around for that to be integrated. And I think that we're all going to find our comfort levels. I know that I was always uncomfortable when I would go to the bedside of someone who was actively dying and around saying goodbye. I just was always fumbling with that. And then I realized I became quite comfortable with that over time. And I feel the same way about MAID. I feel like we're fumbling and we're not quite sure around what this looks like. And then over time, we may find a way that can be integrated. There's a lot of people that don't know that MAID is even an option. So when we leave it that we can't provide information about MAID unless someone asks for it, I feel that we are just then actually furthering the marginalization of other groups because you don't know what you don't know. So how can you ask about something that you don't know even exists? So in terms of, are you interested in hearing about the end of life care options that are available? Where do you turn to for resources and support and to be able to make sure that those avenues are then aware and comfortable? That is another piece that we, receive those calls from people that I didn't even know it was available. I didn't even know that MAID was an option. No one's talked to me about it. So those are hard phone calls. And I know that there's that tight balance. We don't want to encourage it. We don't want to be, I absolutely understand that as a clinician. And it's, again, finding that balance between making sure that people know that it's available as an option.
That's great. Thank you so much for that. And thank you both for being here today. I'm just recognizing we have only a short 3 minutes left in our time with the both of you today. So I'll just open up to both Elizabeth and Tammy, if you have any final tips or sage advice for those that are on the call before we sign off. Elizabeth, why don't we go to you first?
Sage advice, I don't know. No, I just think that the nurses can be champions in having these serious illness conversations and definitely explore the values and wishes of the patients that they are caring for. And that can include MAID if that is something that the person has identified is an option for them. But there are other on the palliative care unit at BGH, oftentimes there would be something like palliative sedation, where we're keeping somebody comfortable at the end of life. But it's really about their preferences, their priorities, what's important to them, and where they want to be. And I think we can advocate to support them.
That's great. Thank you. And Tammy, over to you.
Oh, I very much echo what Elizabeth has said. I agree with that wholeheartedly. The only other piece that I can think of is when it comes to either that you're not an island, that there is support available certainly for you, and also to utilize your team. So as nurses, you are so incredibly skilled and compassionate to be able to have these conversations, and to know that you also have a team out there as well.
Great. Well, thank you so much to both of you for joining us today and sharing, some really incredible and detailed information. I think we'll all have a lot to digest. So, and thank you for offering to share your slides with the group. So we're happy to circulate those after the session with the YouTube recording link. Thank you for everyone who has joined us today. Just a reminder that if you'd like your Oncology Nursing Day gift, expect to see an email with an evaluation survey and a link to the recording on the YouTube channel. Thank you for all that you do. Today is about all of you on the call today as oncology nurses. You're amazing, and have a great day. Bottom line, have a great day. Thank you, everyone.
Thank you.